everybody. Welcome. My name is Alicia Staley. I am an e-patient advisor and a Medicine X e-patient scholar. I'm also a 3-time cancer survivor, going on my 27th year of cancer survivorship, and I'm very excited to be here on this panel today talking about how we might be able to improve cancer care and the cancer experience. You met Charlie. He just gave his presentation. I'd like to introduce Peter Bach, Dave Taylor, and Tonya Bellotti. And I'm going to start with Peter and ask Peter to just say a few words about himself.
Absolutely. My name is Peter Bach. I'm a physician at Memorial Sloan Kettering Cancer Center, where I run the Health Policy Research Center. And actually, we've been working with Charlie and ProPublica and Inspire on this issue of trying to give patients and or consumers, which is sometimes the word, some ability to select the places for cancer care based on data that's objective and understandable.
Mm-hmm. Dave?
I am the Senior Director and Head of the Research Department at Inspire. Inspire, of course, is an online patient community with over 1.2 million members, and my group is responsible for interacting with them and asking the questions, like Charlie had mentioned, that we are interested in learning about. So we liaise with agencies like ProPublica and MSK, along with pharmaceutical companies directly, to gain those insights and inform healthcare moving forward.
Great. Tonya?
I am a 10-year advanced triple-negative breast cancer survivor. And I've had a couple surgeries and lots of chemotherapy, and I'm just here to share some of my story.
Well, thank you all for joining us today, and I think we're going to dive right into this topic because it's very important for us to really understand what this data and research is telling us as healthcare consumers. Peter, I want to start with you. This is a topic that you've been researching for a number of years now, over 16 years if I'm not mistaken. What's changed from when you initially started researching this to what you're seeing now in this latest report that's come out?
Well, we were part of the recent report, but Charlie put up a slide of an article that I'd had in the New England Journal so long ago that it's actually in black and white, which I only noticed standing there backstage. So that was 2001, that article. That was actually a follow-up of research that we had done in 1998, showing these very large differences in outcomes for patients with cancer based on where they were treated. And Charlie mentioned the major thing we looked at the first was just how many surgeries these hospitals performed, and that was highly predictive of how well patients did. You know, with appropriate adjustments and stuff. I mean, this is what we sort of do for a living, is this kind of observational data. And then when we went on that paper, we showed almost a 10% difference at 5 years for people having lung cancer surgery who went to hospitals with expertise or volume and went to ones versus those who didn't. And nothing has changed except the New England Journal is now in color.
And we laugh, and that's it's so hard to even wrap your mind around the fact that there's been research reports out there for a number of years that are saying that in order really to, I guess, receive the best care, you have to seek out the institutions where this kind of care is being delivered on a consistent basis. Is there anything else that you'd like to add from that
sure.
research?
So what motivated us is that I think what you've said is true, that you should seek this out, or it makes sense to seek it out, but there's no way to actually do that. Or in fact, we weren't allowed to identify the names of the hospitals in our study. Mm-hmm. And so that was the motivation at some level, is, you know, these are robust differences. We should allow patients to find their way to the places where they can have the best outcomes. Yeah. And hopefully it will also have the effect of improving the outcomes at the other hospitals.
I was sharing with Charlie earlier today that I actually grew up in Western New York, and I was not the only person diagnosed in my neighborhood with Hodgkin's lymphoma. There were actually 6 of us altogether. I was diagnosed with Hodgkin's disease. My best friend was diagnosed with non-Hodgkin's disease, and there were 4 other gentlemen that were diagnosed with a form of lymphoma. I was the only one that actually went to an academic medical center for my initial treatment and my initial surgeries. The rest of them actually sought out care at the local hospitals or the regional centers. And today, I'm actually the only one that's still alive of that group. And I often wonder, was that decision to go to an academic medical center for treatment a differentiator between me and the 5 other people in my neighborhood? So when we talk about percentages and differences, 55% at this point or 43%, they might represent numbers in a research report, but they're real people. And there's real outcomes that don't get shared sometimes with these numbers. And for me, it's, I'm on a mission to help cancer patients find the best treatment, regardless of geography, regardless of their economic and socioeconomic backgrounds. And I think research like this really points to there's still a gap. We're not getting the word out to the people that need it.
Well, it makes me so angry. It's like, are we sentencing people to death based on the fact that we're not providing information to them? That information that we have, information we've known for, as Peter said, now close to 2 decades, actually makes a difference. And yet, in this audience, you're not entitled to see this information. Who is deciding that you're not entitled to see this information? It really makes me mad.
Yeah, it's very upsetting. I mean, just to think of my cancer journey, could it have been different just based on a decision like that at the very beginning of my journey? But Dave, I'd like to, bring you into the conversation and just add your thoughts on what is it that drives the consumer decision in the context of what's out there today. The lack of information is one thing, but still people are making decisions to seek out surgery or treatment at hospitals that might not necessarily be the closest ones to them. They might choose by reputation or a marketing campaign that they see. I mean, that's all reflected in this data.
Yep, and one of the things that we saw in the survey is that just under 50% of the patients, and we're talking 3,300 plus, did not choose the closest treatment facility for them. And so, being a data jockey like I am, I started, looking into that, and I found that those that chose to go further out, whether it's 2 blocks down the street or the next state over, they put a higher emphasis on the reputation of the treatment center, patient satisfaction, as well as, and I'm drawing a blank up here, volume, to Peter's point earlier, volume of surgery done each year. So these individuals tended to be, and I was shocked to hear it's a dirty word this morning, engaged group of patients. While health literacy has improved greatly in the patient community, the people in this room probably represent this, top 1-2% of all people in healthcare. Mm-hmm. And so information, to Charlie's point, needs to continue to be disseminated to these individuals so they can make informed decisions and choose what's best for them.
And I think, but Charlie, you've made the point. What is that mechanism for sharing that information? If Peter has talked about research that's decades old at this point, and that word is still not getting out to the community at large.
It feels unfair to some extent. My mother-in-law had heart valve surgery a couple of years ago, and she was trying to decide where to go. And she knew that we had access to Medicare data that the general public does not, and she wanted to know if her surgeon had a lot of experience performing this heart valve surgery. And so we looked it up, but you couldn't look it up. That just feels wrong. And I know you, Peter, you had a similar experience,
I did that
right?
for a friend of mine who was seeing a surgeon, and while he was waiting, the surgeon was running late, and while he was waiting, we looked him up, and I told him to get a taxi.
Jeez.
But shouldn't you be entitled to that same information? That's the thing that just seems patently unfair.
Yeah. It's levels of access to information and sort of these hidden pockets of who can access, what we call tips and tricks, I guess, in the e-patient community. But it's an access issue, and we go back to, is it a fundamental right to have the best information that you can get your hands on? And when data stays locked up or not shared in a way that's meaningful for the community at large, what do you do? what are the next steps?
Well, there's no question. I think transparency is, net beneficial for everyone. And like I said, part of the hope is that by bringing these things to the fore, that places that are underperforming will find ways to improve, or find other things to do and not those specific procedures. I do want to be cautious. I'm sitting here, as a doctor at a major cancer center, and we're talking about this. This is not an advertisement. We consider ourselves, or I consider my hospital, subject to the exact same kind of scrutiny that every hospital should be subjected to. And to the extent that we perform great, and to the extent that we don't perform, we should be getting to work. But I also think the interesting thing about the survey, at some level, is so you've got a bunch of data jockeys up here, is that what we heard, things like reputation, kind of came to the fore, and things like if you would be alive or dead at 4 years didn't. So I think it was 14%, 12% of people wanted that information. And that's really, I can't think of a more probative word than intriguing. And I'm actually not sure how to unpack it. But as a data person, it's like, why wouldn't you want that? That's what we can figure out.
Right. Well, I think, and Tony, I'm going to put you on the spot here with this question, but we've discussed this before, Charlie. The idea of how satisfied were you with your surgery? If you're having surgery for the first time, what is your benchmark for coming up with, I was very satisfied with my surgery?
Because I woke up. Right.
Is that the benchmark?
It's an important one. It varies a lot.
Yeah.
It does.
It's very true,
Right.
but I think I find it very hard to you get home from the hospital, you're recovering from surgeries, and I've had a few in the last 27 years, a couple. But the first thing that arrives in your mailbox is a survey from the hospital or the surgeon group asking you how satisfied you were with your surgery. And I'm thinking, I had a bilateral mastectomy once. I don't want to have it again. And I have no idea how to rate this experience, because it's not a transaction that you can repeat. So it's not like I'm out buying shoes and I'm going to go and buy another pair of shoes and this experience was so much better the second time. It's not something that you want to repeat. So the idea that you can have a satisfaction level assigned to a surgery, I think, is very interesting. But Tanya, I want to get your thoughts on that.
Yeah, I think for me, the satisfaction rate would be, in particular, a cancer surgery, if it's just one, or do they have to go back for more, if the margins are clear, how the surgery looks afterwards, if there's complications, all that kind of stuff would play into whether I'm satisfied or not. I did have a surgery where it was completely different than what was explained to me, and that was the only time where I felt that I understand why the surgeon did what they did, but I didn't even know that was a possibility going into it, what I walked out with. So I think communication is a big part of it too, but getting the cancer, making sure you look decent, and just no complications would be a huge indicator for me that it was a satisfactory surgery.
And you talked a little bit about communication, and information gathering
Right.
is part of the sort of pre-surgery process.
Yeah.
Can you speak to that a little bit? What was the process that you went through to make your decision on your surgeries?
Well, the upfront surgery, the lumpectomy, I was part of the Kaiser network, so I could not go anywhere I pleased. I had to choose within the Kaiser system. So I did research on their website. I met with a couple surgeons, got a feel for how I interacted with them and how comfortable I was with them. And then because I wasn't at a major cancer facility, I also opted to pay for a second opinion out of pocket to see if it lined up with what the Kaiser surgeons were telling me, and it did. And so it gave me a level of comfort that I didn't have prior to getting that outside second opinion.
Did you take into account how long you'd have to wait for surgery as part of your decision-making process?
Yes,
even
absolutely.
within network?
I did not. I was already stage 3 when I was diagnosed, so I felt like I had to move on it. I couldn't wait for months to see a doctor, so I was able to get a second opinion and got it from the doctor that I could get into the quickest.
So this question is really for all of you. What research or what additional stakeholders should be involved in these kinds of conversations around this research in particular? It seems like the major stakeholders that should be paying attention to these kinds of reports aren't really acting on this information. Do you have thoughts on where do we take this research, and how can patients help change this conversation? I stumped you.
I mean, I think that one of the things is what we saw this morning on the panel is it may come from this group or someone connected immediately to us, innovation from within almost, and starting the groundswell to make this information publicly available. And one of the things that we will have to figure out is, how do you define satisfaction? It is such a subjective measure, and it's not just from patient to patient. It's within a household. Mm-hmm. Of the 300 plus caregivers we heard from in the survey, they were typically more critical of the cancer surgery experience than the patients who were responding. So, having that internal advocate that's getting information and understanding things as your second set of eyes and ears, their expectations may not line up with the patient themselves. Again, the patient wakes up, hey, that's great, we did a good job.
Yeah.
But if it took longer than expected, there's a medication reaction during the surgery or things like that, it may affect someone else differently. And so understanding what's good, what's bad, standardizing that, and then again, pushing it out to the forefront through technology is going to be key moving forward.
Backing up to so a long time ago, I started working in these areas, and then when Charlie and I started talking about presenting this and, trying to do something that would be helpful to people for locating places to get care, we sort of looked at one another, and I hope this is a fair characterization, and realized that, and Charlie's an expert in reporting, news and data, and that's sort of what I do into the medical community as well. But nobody had really thought through, before we go build this thing, should we actually ask patients what information they might want? Mm-hmm. And, you should go ahead and laugh at me now. This seemed like an amazing insight. That we would actually ask patients what information they would actually seek before they made this, as opposed to us sort of dictating, well, of course you want risk adjusted, for your mortality, right? I still think those things are important. We have to figure out how to wrap them up in something that helps people make decisions. But when the work we did with Inspire, we read the literature, we called everyone we knew in the field who had been doing profile, the topic is called, the category is profiling. In other areas of healthcare, we couldn't find anyone who had just taken that step. The government has websites that rank hospitals and complications. I don't think anyone ever asked the customer, consumer, patient party you were trying to help. What would you actually want to know? Some of the things we can't measure, right? Well, but it was like a eureka moment. Know your audience. No one's ever thought of that before.
I wanted to go back to your question in terms of the who needs to be in the room. Imagine if this group or the breast cancer social media decided we're taking this on, and each of our members is going to call their hospital and get data on the number of surgeries they performed in each of the last 3 years, and what are your survival rates. And we're going to call out the hospitals that won't disclose it, and we're going to put online what they say, and build it yourself. I mean, that's what you guys do in this room. That's what Medicine X does. Why not adopt something like that and do it? And I think people are very afraid of naming and shaming. It's people, we want to work together. You see this with hospital accreditors, right? This is not about punishment. This is not about, we want to work together and let's improve. But yeah, we want to improve the bad actors, but I don't want to go to a bad actor today. I'd like them to improve tomorrow, but don't send me in there today. I want to go to a good actor today. And I just think everybody's a little timid, and patients may not want to sort of anger their doctors, although I know some in this room are perfectly happy to do that, and I know some of you, and I love you for that. But a lot of people are very afraid of sort of an adversarial relationship with their doctor or their hospital. But if they won't do it for us, we can force them to do it. And like, I think that may be the new attitude that we need to bring.
Tonya, how do you see that playing out in a moment today in a visit with a new patient, with a new surgeon, they're meeting for the first time? What would you suggest that they do, or questions that they should ask the surgeon to sort of facilitate this kind of conversation or have a better understanding? You know,
Right.
do we go into our surgeon and say, hey, show me your stats? You know, what is that kind of interaction?
I think it's okay to go into a surgeon and ask them specifically how many of these surgeries they did. I found that most of the time they're more than willing to share that information with you or tell you about their background. I think for me, I would also tell somebody, my surgeon allowed me to tape the whole conversation so that I could go back and listen to it. And even though I didn't do that, it was there if I needed to. Also, she was able to draw a diagram, so I knew exactly what was going to happen, the lymph system, so she gave me a level of comfort, and I would suggest that, if it was somebody that I knew, I would say, yeah, you need to ask them if you can ask them all the questions, go in there prepared, take somebody with you, tape the conversation, that kind of thing I think it's perfectly okay to ask those questions.
The other thing is we have to let people know what questions to ask. If you're diagnosed at stage 3 with triple negative breast cancer, and the first step on the treatment scale is surgery, you know, it's about getting it scheduled, getting it done. Let's get the cancer out and then move forward with treatment. And that's what your concern is. You're not thinking, well, how many surgeries have you personally done? Has the hospital done? What's the success rate on, you know, this kind of treatment? So to educate the population in terms of what should you ask, that's going to be step 1, and then collecting the information is the other side of that.
Yeah.
Although I think that there's something that's actually more fundamental than that, because I think to a certain extent, when you design a tool and make the information public, your audience is in fact the public. But I think Peter said something that is really on point, which is your audience is also the hospitals. And even if patients don't use it, no hospital wants to be ranked worse than their peers because it's embarrassing. And sort of the publicity around something like that is enough to change behavior, such that if you're a patient and you don't ever want to ask that, and you don't even look at those rankings, you're going to choose based on reputation, the attention from within the hospital to improve is going to be a lot greater when there's public attention than when it's all done sort of privately. And I don't know if you want to...
No, totally, right. These are not static things at all. Right? So, you know, we're way behind, I think, at this point in cancer, but we've seen it with cardiac surgery, with infection control in the IC, in intensive care units, that, you know, the process of measuring leads to people to seek systems that will allow them to improve their performance. That's really important. And so, I mean, Charlie used naming and shaming, and that's a version of transparency, but it doesn't have to be that way at all, right? It can be this sort of more constructive thing. But I think the reason Charlie's incensed, and I'm incensed that I published a paper and nothing happened. So now I've been incensed more over the course of my career, because that's always what happens, or doesn't. But there's this sort of like, at some level, there's this sort of middle territory of everyone can improve, right? But there's also this sort of like, healthcare is special, everybody's patients are sicker, this measurement doesn't uncover a lot of the stuff. Like, we're not actually performing worse, we're actually performing better, you just can't see it because of our patient population. Those sorts of things, those kind of things to hide behind have largely dissolved. And so along with getting people to improve, there's still this sort of fundamental problem, and we were talking outside, and so I'm going to point to some examples I don't know well, but you know, we have in other areas of our society where people expose themselves to risks they can't otherwise perceive, right? Sort of put their hands puts their lives in the hands of others. We shut down things that have failure risk, right? So, you know, fast food chains have like an E. coli thing, and they're shut down, right? And American Airlines, I think it was, if I have the wrong airline, it's not, I'm trying to impugn them. They had some problem with something in some model of their airplane, and they grounded hundreds of them until they made sure that it wasn't. And we have that because we have airline safety, and the American public expects if they get on a plane, it's going to be a certain standard, right? And same if you walk into a restaurant, the food won't have E. coli. And the data in healthcare and in cancer care looks way worse than American Airlines would have looked if they kept flying those planes, or if Chipotle had just stayed open. I mean, it's shocking. The difference, so my friend had esophageal cancer. The difference between high volume and low volume hospitals doing the surgery is an 8% absolute difference in 30-day death from the surgery. That's 8 out of 100 extra people dying within a month of the surgery because they go to a place that isn't good at it. That's
But why aren't the
shocking.
patient population, why, the information is out there, but it's not getting to us?
It's not really out there,
that-
right? We
that
have,
we
I mean,
can
that was
consider.
the whole point, is that Charlie and I have access to this information. You can't really go find out
Right.
which places have expertise. If you ask doctors or hospitals what their mortality rate, they often don't know, right? And it's actually not their fault, right? They have their data systems don't run up against the systems that we have to figure out if people are alive or dead.
So one thought that I want to sort of put out there, there's the idea of marketing, you turn the TV on today, or you listen on the radio that we're the greatest, or we do the most cardiac procedures in all of New England, or, and there's a marketing machine that goes with the delivery of care, that if I'm in the car during rush hour and I hear, oh, we did the most cancer surgeries last year, that sticks with you. And somebody newly diagnosed, oh yeah, go to XYZ hospital, they do the most cancer surgeries every year. And we become sort of these little marketing engines that spread the catchy phrases that we hear. But as Charlie has said before, what are the actual outcomes behind those marketing campaigns? So they're doing the most volume, but what does that really mean for the patient? It makes it much harder for the patient to consume information around actual outcome data, if they can actually find it, because they're competing against this message.
But it's also more than that. It's also about volume, because you don't see hospitals advertise, we perform 1 cancer surgery a year. Yet when you walk in the door and you're number 1, they will perform that cancer surgery on you, some of them. Some won't, actually. Some top-name hospitals have decided we're not going to allow our doctors to perform certain surgeries if we don't perform enough of them to be competent. But other hospitals will still do that. So we're here in California. The California Healthcare Foundation has put out information about volume at cancer hospitals by type of cancer. And there are hospitals in California that do 1 or 2 a year. Do you want to be that one? Do you want to be the one cancer surgery that they do? I don't. But you don't see an ad about that.
At what point does this become, and maybe it already is, an ethical issue, an ethical concern? Did I just say the wrong E word in the e-patient conference?
I mean, I think it's long been an ethical concern that hasn't been acted upon, right? And it's not, in our data, Charlie it was nice to put up our paper, but it's one of many. The Institute of Medicine put out a report on this, which is a very august body that, summarizes the evidence for Congress about, the current state of healthcare, and that thing must be 15 years old or 14 years old. So I think, to your earlier question, I would say that the branding and reputation is at best loosely connected with actual empiric evidence of the excellence that's claimed.
So how do we educate the patient populations about that when you're competing with the marketing dollars that some of these institutions have? We're swimming upstream.
I think a lot of power goes to patient communities, right? And whether it's patient communities like Inspire or patient communities like the one you lead, that you have an immense role to play, and your networks in terms of sharing information are in some ways greater than our networks. I mean, when you publish in an academic medical journal, it is a very narrow network. When you publish in a media organization, it is hopefully a somewhat broader network. But when you actually have groups that are like, this is the affinity group, these are the people who are being affected, this is a huge captive audience. Those are the groups that you need to see much more sort of invested. And that's sort of, if there's one takeaway, it's that if you don't see that change happening on the outside, you can make that change, right? You can do that yourselves, adopt that as a project, and make it happen. And so I throw it back to folks like Dave and you, is that this really is, you guys can own it.
Mm-hmm. So Tanya, what do you say?
Yeah, I think it's, I think that we could really be the driving force on this. I see on the social media sites where patients are talking about their care at different facilities and their feelings surrounding that. I've also come across patients that don't even want to know anything about their treatment. And I find that shocking, but they don't care to know. And they'll just go on basic recommendations. But I do think the patients are where we're going to get our best information. And if we can kind of facilitate that, that would be a really good way to go.
So best case picture, let's roll this out, not another 16 years. We're not going to make you publish another paper that
It's
doesn't
nice
go
to
on.
publish in there.
Where would you like to see this go? What would be the next steps that, as a patient community, that we could gravitate to? What's that first initial step that you would suggest that we take?
Well, hopefully Peter and I can be up here again next year showing you what we've done, right? So I don't think either one of us intends to drop this. If, in fact, just the opposite, based on the feedback we got from the patient community. I think it's informed both of our thinking on this topic, and we intend to keep plowing through with this. And I think it's a really unique collaboration. Generally, you find journalists who think they know everything, and researchers, maybe Peter's the exception, who think they know everything, and they don't feel that they need to sort of talk beforehand. And I think what we're doing is really unique in the sense that you're bringing two people who come at things from a very different perspective and are addressing how do we solve this problem that is in a way that may be novel. So ideally, we'll be back here in a year talking about what we've done, but hopefully you will too, and you'll be able to say what you've done, and we'll see this movement within the Inspire communities as well to keep giving people the tools, the questions to ask, that you'll be asking the questions and drawing attention to hospitals that won't answer them. What I always say to folks is, whatever the topic is, whether it's conflicts of interest in medicine or other things, that if your doctor or hospital doesn't want to answer your question, you need to run, right? There's no reason really that they shouldn't answer your question, and that is the biggest red flag that there is when somebody doesn't want to discuss it or doesn't have time to discuss it. If you want to say, how many have you done? And they're like, I'm sorry, we don't provide that information. It's I'm sorry, I'm not going to go to you. Because that is vital information. So I think that's the way to do it.
Yeah.
My recipe.
I would say something like that number you won't disclose to me just went down by 1.
That's a better response than mine.
That's why we're working together.
Yeah, exactly.
That's a great. Dave?
No, I mean, I think that's right. I hope we are back here in a year, and I think it will be pretty cool. There's a real opportunity to bring data to the fore here in a usable way, and that I have a team of methodologists who think this kind of stuff is fascinating to try and do squarely and objectively, and so we're working hard to try and make sure that whatever needs we're hearing are out there to meet them in a way that can be trusted.
And beyond individuals going at this, how many advocacy organizations are there in the country targeted for each different type of cancer? Leveraging them to start putting pressure on treatment centers to get this data and be able to disseminate it to those that are affected by these diseases is a route that you can go.
Mm-hmm. Tanya, any thoughts?
I don't know if one thought that popped into my head is when we go about, we can get involved in the groups that we know for our individual cancers. But also, I am curious to know what the patient's role would be more. For instance, are they included when the surveys are made up and things like that? I mean, are they part of that process? Because I find that it's great to get this information, but there's also some human elements to it as well, as why you would go to a certain facility that maybe not be able to measure or weren't asked in the original survey. So
That's a great point. I think it's a lot to ask the patient advocates to take the data and run with it. But I think the patient advocates become much more invested in the process when they're invited in to help build the structure for the surveys and build the initial foundation of the conversations around, all right, here's our issue. What can the patient voice or the patient perspective provide that might be a little different? Like you said, you went to the patients, or you asked patients what they might want to see in a survey, and you were sort of shocked by, or that revelation was sort of shocking. But the patient perspective, I mean, we've sort of been living this journey for a number of years, and these are hard-fought wins for all of the patients and the patient advocates. And I think one of the methods, or actually one of the sort of feelings that the patient community have is no patient left behind. We have gone through a journey, good, bad, or indifferent, but when we're at the end point, or we've made it through sort of the darkest days, we're more than willing to turn around and lend our hand to the people that are still walking up behind us. And I think that that's a very different, a very special place to be when you have advocates that are willing to stay in the trenches and help bring the rest of the community along to a healthier endpoint. And being involved in the process as early as possible, I think will benefit the whole continuum of care. And I think that process like this with the survey that you did, including the Inspire communities, that is where we need to be, and we need to see more efforts like that going forward. But the data and the results are amazing, and I'm looking forward to seeing the next steps or the next iteration as we sort of roll this out. But any last thoughts from the panel as we come to a close here this afternoon? Anything that you'd like to add, or questions that amongst the group here?
I just want to see, folks, like when you talked about the 6 people from your community who were diagnosed with cancer in a short time period and all but you have passed away, I would like to make sure that let's up that number, the people who are still living. And while it's great to focus on cures for the future, there's a lot of people who are dealing with this today, and we can't forget about them.
Mm-hmm. Yeah, I mean, there's an element of this visionary idea that when we approach improving healthcare, we're so visionary, or we're so, in 5 years from now we can fix this, but there's somebody that's in a doctor's room right now somewhere in the United States being diagnosed with cancer for the first time, and that breaks my heart, because somebody else now has to go on the journey that I've been on over the last 26 years, and it's not fun. But you have these pockets of excellence around the United States of different organizations, different healthcare organizations that have really improved the cancer experience. But when you see numbers like we saw today, where there's still so differences between different kinds of institutions, it's as an advocate, it's devastating to see that these numbers still are where they are today. But we're getting there, I hope. Any last thoughts? Did I see some questions? Ooh. Do we have time for questions? Did I just hear a no from?
No.
I'm sorry.
We're around.
You can find me after or tweet me, and I'll answer your question. But thank you very much to the panel. Thank you, Charlie, for your presentation.